Indian operating rooms look cleaner and more advanced than ever. But in 2026, an invisible crisis is threatening modern surgery itself. I have spent more than 20 years as a surgeon. I've seen every kind of complication, but what I'm seeing in Indian operating rooms this year is a terrifying first. A senior medical whistleblower had just come forward with leaked data showing an invisible crisis. It's a threat you cannot see with your eyes, and yet it is changing how we can safely operate. Today I will tell you what is happening and why we must act now. When you walk into a modern hospital in India, you see bright lights, polished floors, staff in gowns. It looks clean, it looks safe, but looks can lie. Over the last 2 years, we have watched a quite terrible shift. Germs that used to respond to our first-line drugs like carbaphinamines are failing more often. In some hospitals, infections after routine surgery do not clear in 48 hours like before. Instead, they linger, they get worse, and they need long ICU care. This is not a few isolated cases. It is becoming common enough that surgeons talk about it in staff room. We now spend more time managing post-operative sepsis than curing the original illness. Support for this rise in carbaphinamine resistance and increased hospital burden. We expect the operating room to be a shield, but that shield is only as good as the system behind it. Old or badly maintained air systems like HVACs and filters can circulate tiny particles. If those filters in those systems or ductwork are faulty, air that should be clean moves germs from one ward to other. Overcrowded urban hospitals make it worse. When beds overflow, sterile routines fray. Staffs are tired, small shortcuts become normal. And those little errors let germs find a way right into our surgical fields. Evidence that air systems and filtration matter for germ load. The next piece surprised many of us in medicine. Our environment is not innocent in this story. Wastewater from some drug factories contain antibiotic and resistant genes. That polluted water becomes a kind of training ground where bacteria learn to survive, even our strongest drugs. From these water tables, resistant bacteria can get into food, animals, and people long before anyone is admitted to hospital. That is how a patient who never took a particular antibiotic can carry resistance when they come in for surgery. This has been documented in many industrial areas across the country. I have spoken to colleagues who now say no to some elective procedures. Not because they lack skill, but because the risk of a life-threatening infection can outweigh the benefits. When patients do get infected with these resistant bugs, they stay in ICU weeks longer. Families lose wages. Hospitals use far more resources. A once routine appendectomy can become the start of months of suffering. This is not just medicine, it is human cost. What we must do? We can fix this, but it will take systems, not just prayers. First, real-time genomic surveillance in our big surgical theaters. Let the laboratory tell us, hour by hour, what bugs are in the air and on surfaces, what kind of data stops outbreaks early. Second, clean up the source. Zero discharge rules for pharmaceutical plants. No more dumping antibiotics into rivers and soils. If we cut off the supply of resistant genes at the source, we slow the problem. Third, a strong national stewardship program. Train every doctor, every pharmacist, and every hospital manager to protect our last drug, the reserve antibiotic, for when there is truly no other choice. And finally, fix infrastructure. proper ventilation system, proper maintenance of the ventilation system, enforced sterile protocols, and less overcrowding. These are not glamorous fixes. They are hard work, but they are necessary. The national action plans and surveillance network from organizations and health agencies are our best roadmap. Please understand, this is not to scare you. It is to ask for careful action. Do not demand antibiotics for every fever. Ask your hospital about infection prevention. Speak up if you see poor hygiene. And to policymakers and industry, this is a call to responsibility. Antibiotic resistance does not respect fence lines. What follows out of plant affect what happens in an operating room. We are not helpless, but we must act decisively. If we delay, surgeries will become riskier. The very thing that saved so many lives, the modern surgery, could be set back unless we reclaim our operating room now. If you are a doctor watching this, talk to your team. If you are a hospital manager, fix your air and your processes. If you are a citizen, ask questions and use antibiotic responsibly. If you want, in the next video, I will show you step by step what a practical bacteria surveillance setup looks like for a theatre and what the cost and time actually are. For now, please like, share and subscribe. This is not a problem for doctors alone. It belongs to all of us.